Okay, so you got bradycardia that is symptomatic. So what is bradycardia? Bradycardia is heart rate less than 60 beats per minute, or the patient has symptoms of bradycardia, such as confusion, altered mental status, chest discomfort, and poor perfusion of their extremities. So what do? You first assess the patient, you do a focused physical exams, get their vitals, their mental status, their pupils, are they constricted or dilated, pulmonary edema, murmurs, are they warm or cold, any other symptoms. And then you review their recent EKG, get telemetry and labs, any current meds, recent dose changes. You get a 12-lead ECG and have the pacing pads available. Make sure you place them immediately on the patient. And you get IV access. So you draw BMP, and magnesium lactate, and troponin, and you monitor the blood pressure frequency, keep the oxygen saturation above 92%, maintain the airway. If the patient is unstable, you first try atropine, so 1 milligram bolus over every 3 to 5 minutes with a max dose of 3 grams. You don't give this if you know they have Mobitz type 2, heart transplant, or complete heart block. If that fails, you can try dopamine IV infusion, 5 to 20 micrograms per kilogram per minute, or epinephrine IV infusion, 2 to 10 micrograms per minute. And you give antidotes for any causes, such as beta blocker overdose, you give glucagon. For calcium channel blocker overdose, you give calcium plus high dose insulin. For digoxin toxicity, you give digibine. For opioid induced bradycardia, you give naloxone. For hypoxia, you give oxygen. For hyperkalemia, you give calcium. And let's say that fails, or the pads are placed and you go ahead and do transcutaneous pacing or transvenous pacing, which you need to consult cardiology. And for transcutaneous pacing, you want to anesthetize the patient or give them analgesia. For if you're just giving analgesia, you give 2 milligrams lorazepam plus 2 milligrams Dilaudid, or if you want to intubate them, you give fentanyl plus midazolam, and then you intubate, and then you turn the pacer to 100 beats per minute, set the output to 100 milliamps, and you go ahead and do that. They're gonna stabilize after that point. And when they're stable, you monitor and assess for reversible causes, so the H and T's that I talked about earlier. And if it's Mobitz type 2 or complete heart block with wide QRS, they always get pacemaker. And you hold the antihypertensive meds or nodal blockers, such as beta blockers or calcium channel blockers. And let's talk about diagnosing bradycardia. So the first thing you do is say they have bradycardia. So you see if there's P waves, is there normal sinus rhythm? So if there's not, it's either sinus arrest with junctional or ventricular escape, or atrial fibrillation and flutter. So with sinus arrest, there's going to be no P waves during the pauses, and then a junctional escape in which you have a narrow QRS and heart rate either 40 to 60 for junctional or 20 to 40 with ventricular. And then you're going to have a sudden long pause with no electrical activity, and then the escape rhythm kicks in. For atrial fibrillation, you're going to have no P waves, and it's going to be a irregular rhythm. The atrial flutter is going to have sawtooth flutter waves. So the RR intervals are irregular, but the flutter has a predictable rhythm that has a 3-to-1 ratio, or specific ratio. Okay, so let's say the P waves are present. So in that case, are the PP intervals, the time between each P wave, same? If not, then it's a sinus pause, sinus arrhythmia, wandering pacemaker, or non-conducting PACs. If it's a sinus pause or sinus arrhythmia, then basically the rhythm will pause and then stops and starts again at a regular rate. The arrhythmia is if it slows or speeds up. Wandering pacemaker is the P waves change shape. The non-conducting PACs is the P wave comes early and changes shape of the preceding T wave as it's buried in that complex, and then there's no QRS afterwards. So, okay, let's say that the PP interval is normal. Is the PR interval normal? If not, it's Mobitz type 1 or complete heart block with junctional or ventricular escape. So Mobitz type 1 is a progressive lengthening, Mobitz type 1, yeah, is a progressive lengthening of the PR interval until the QRS drops. And so you're going to have more P waves and QRS. Complete heart block is complete dissociation of P waves to QRS. So you're going to have the two working independently. So there's either going to be a 40 to 60 rate or 20 to 40 rate. And okay, let's say the PR intervals are normal. So then you have either sinus bradycardia, in which there's equal amounts of P and QRS waves, or you have Mobitz type 2, in which there's a random drop of the P wave, which causes there to be more P waves and QRS. Random drop of the QRS, so you're going to have more P waves and QRS. So another thing is, if you're in between Mobitz or 1 or type 2, if there's a second degree AV block with 2-to-1 conduction, then it's hard to tell. So basically, if they're symptomatic and it's either Mobitz 1 or 2, you go ahead and give them the pacemaker anyways. And other causes of bradycardia, so you could have meds that cause it, degenerative calcific conduction. You have elderly patients, hypoxia, autoimmune, infectious causes, status post TAVR, increased vagal tone, increased ICP, hypothermia, carotid disease, plus recent stent, infiltrative disease, hypothyroidism, sleep apnea, athlete, drugs or toxins, ischemia, ACS, endocarditis, Lyme carditis, myocarditis, pericarditis, hyperkalemia, or status post septal ablation. And the antidotes I've already stated. So that basically goes over bradycardia.